Where is it? Here we go. So I've got to fill out a food log before I go to my nutritionist's office. Well, I gotta finish it. So yesterday was the 18th. I didn't really eat lunch yesterday, so I think I'll just say I had a salad or something. I don't like making things up for this, but I kind of feel like I have to. I feel pressured to do it just because if I'm not following all the rules of my treatment, then that's when people start talking about higher levels of care, and that's really scary. So okay. Had an eating disorder for 8 years, since I was 13. I didn't start treatment and I wasn't diagnosed until I was 19. I was at a point in my life where the disorder was unmanageable, completely unmanageable. So I asked for help and I got it.
Eating disorders are typically presented it's 90% of the cases are females. And they used to be thought of as a primarily sort of white, upper middle class disorder, but that is changing over time. So, without treatment, 20% of people with a serious eating disorder die. That rate drops to 2 to 3% with treatment. People have better success when they go through an inpatient or a higher level of care first, generally speaking, and they also have better success when they treat an eating disorder early. The general rule of thumb is that about a third of people recover fully from their eating disorders. A third of people recover mostly but still have occasional relapses or struggle with, kind of body image problems or, kind of intermittent symptomatology related to eating disorders. And then a third of people chronically struggle with eating disorders and don't recover.
So I have eating disorder not otherwise specified. That means that I don't meet the full criteria for anorexia nervosa or bulimia nervosa, even though I exhibit symptoms of both. So essentially that's what it is. It's a combination of the two. About a month after I started outpatient treatment, I was recommended to go to an inpatient facility. I lasted a couple days and then I demanded to be let out. It was pretty awful. So right now I'm in outpatient treatment. That means that I see a therapist twice a week. I see a nutritionist once a week, and I'm supposed to see a psychiatrist once a week as well, but I don't have a psychiatrist currently. I don't want to be on medication. Outpatient treatment takes about 3 hours a week, and that's just going to appointments. In terms of eating supportive meals, fighting symptoms, just thinking about my health in general, it's about a 24/7 job.
Well, eating disorders are multifaceted. They're both psychological and physical disorders. And so achieving sort of addressing all of those issues on an outpatient basis is challenging for patients in a scheduling sense. They need to attend a lot more appointments than you would just going to therapy once a week. And more than just scheduling, emotionally, you're asking a patient to expose themselves to something they're really afraid of, which is eating regular meals, without a lot of support.
Fun.
People with eating disorders frequently present with comorbid psychiatric and physical disorders. Most common psychiatric comorbid illnesses are anxiety and depression, particularly obsessive and compulsive features are often found in people with particularly anorexia nervosa. Substance abuse and trauma are also really common in people with eating disorders. There's a higher rate of suicide attempts. There's a higher percentage of people with eating disorders who also meet criteria for borderline personality disorder.
There's some sort of mood issue present that coexisted with the disorder. I was diagnosed with bipolar 2. So my psychiatrist started me on an anti-seizure medication. And it worked for a while, but this is gonna sound weird, but I was so flattened, like just flattened out in terms of my mood, that I couldn't write. So I just stopped taking the medication, which is really dangerous. The disorder and my drive to succeed kind of work together weirdly, and it makes it even harder to take care of myself.
It ain't about hard to find. It's about the one inside.
It's my 2-year anniversary of inpatient treatment.
Congratulations.
Happy anniversary.
How does that feel for you? I should have gotten flowers.
Yeah, why didn't you?
God.
No, it feels weird. It feels weird. The first thing they do is take all of my stuff, like rifle through everything. They took everything, all my money, all my cards, my IDs, everything. And then they strip search me.
That's so violating.
Yeah, like, I think at that moment I was like, I don't want to do this, because I didn't feel like a human being anymore. Like, it's at the point in that place where treatment was just crowd control. Like, they didn't have the money to really be able to provide 24/7 constant support. I think that, like, the political part of it started coming through, and like the funding aspects of like, this isn't a place that can afford to be this really nice residential facility where everyone knows everyone. The point of inpatient treatment is to bring someone's weight up, and that's about it. There were a lot of people in inpatient who were like professional patients. That's what they did. They would get into a facility, gain some weight, but they wouldn't learn how to eat meals and to recover by themselves, and then they would end up back. Mm-hmm. And like, so, you know, I saw that, and I didn't want to be that at all.
Inpatient setting is when a patient would actually go and stay somewhere. That can be residential, where they are, you know, free to come and go as they want, or a locked inpatient setting, you know, where someone is sort of forced to stay for a period, or decides to stay, but in a locked setting for a period of time. In an inpatient setting, the dose of treatment is much higher. You're going to have 3 supported meals and 2 supported snacks a day, plus individual, family, and occupational therapy.
There were only nurses who wouldn't eat with us. The idea is that you're eating together. They weren't eating with us. They were just sitting and watching us eat. They were telling us that, you know, if we didn't finish our meals, then we would have to have like these Ensure, like gross protein shakes to make up for calories, and then we would get punished even more by having privileges taken away. So the system was like surveillance and punishment, because these places are acting like they're in panic mode. Mm-hmm. They're taking people who are literally about to die and then trying to get them to a stable weight so that they can function in real life. But in the long term, what does that mean? You turn someone into a dependent patient.
Right. Dependent on this authority figure to force feed you.
Eating disorders are secretive, and they operate with a lot of denial. And so when you're in an outpatient setting, you're primarily relying on the patient to self-report their symptoms and their experiences, and if they're in a place of significant denial where they're even denying those things to themselves, that's a lot to ask of someone. Versus if you're in a higher level of care where you have monitoring of someone, they're going to be able to see their symptoms and experiences in a different way versus having to self-report.
You know, I don't think that I'll ever really be comfortable with identifying with this disorder or with all of the mental illnesses that I happen to have, because they're still stigmatized. And the only way to destigmatize it is through things like this, to talk frankly about them. I'm doing this because I think it's important to show that everyone of every different positionality of all kinds can be vulnerable to a mental illness, that they're very common, and that, you know, it's not a failure on the part of the person, and it's not completely debilitating either, that it's still possible to be a successful person, to be a loving person, a funny person, an intelligent person, all of those different things, even with this disorder.